Namaste, Narendran.
Namaste, sir.
Namaskaram.
My sound audibility is good, sir.
Yeah.
Clarity is good.
Yeah.
Okay.
Hello, sir.
Namaste, sir.
Namaste, Shantanu.
Namaste, sir.
Secretary,
Namaste, sir. Namaste.
Dr. Shantanu, good afternoon.
Very good afternoon, sir. How are you doing?
Fine, thank you.
Namaste, sir.
That you have gracing the occasion.
No, thank you. Thanks for this opportunity.
Thank you, sir. Namaste.
Sir, shall we try sharing the screen?
Yeah,
Just-
you can try.
Will it be visible to everybody?
Yes.
Oh, but is it clear, sir?
Yes, sir.
Okay.
ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ಕಾರ ನಮಸ್ಕಾರ.
Please, sir.
ಸರ್ ಆನರಬಲ್ ಜರ್ನಲ್ ಸೆಕ್ರೆಟರಿ ಸರ್ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ಸರ್, ಸ್ವಲ್ಪ ನೋಡ್ತೀರಾ ಸರ್?
ಶಂತನು ಸರ್ ಲಿಂಕ್ ಕಳಿಸ್ತೀರಾ ಇನ್ನೊಂದ್ಸತಿ?
ಓಕೆ ಸರ್, 2 ನಿಮಿಷ.
ಅಲ್ಲ ಈಗ ಹೊಸ ಲಿಂಕ್ ಕಳಿಸ್ಬಿಡಿ, ನಾನು ಈಗಲೇ ಮಾತಾಡ್ತೀನಿ.
ಸರ್ ಕಳ್ಸಿದೀವಿ.
ಸರ್ ಬರ್ತಾ ಇದ್ದಾರೆ, ಒಂದು 2 minutes ಬರ್ತಾರೆ.
ಓಕೆ ಸರ್. ಶಾರ್ಪ್ 3:30 ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಸರ್. Sir, we are not able to find sir.
ಸರ್ ಹೇಳಿ.
ಸರ್ ಅದೇ ನಮ್ಮ ಸೆಂಟರ್ ಸರ್ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ಸರ್.
ಬರ್ತಾರೆ ಸರ್, 5 minutes ಬರ್ತೀನಿ ಅಂತ ಹೇಳಿದ್ದಾರೆ.
ಓಕೆ ಸರ್.
ಬರ್ತೀನಿ ಅಂತ ಹೇಳಿದ್ದಾರೆ.
ಎಸ್ ಸರ್.
ಹೊಸ ಲಿಂಕ್ ಕಳಿಸಿದಿರಲ್ಲ ಸರ್?
ಎಸ್ ಸರ್.
ಓಕೆ, ನಂಗೊಂದ್ಸತಿ ಫಾರ್ವರ್ಡ್ ಮಾಡಿ, ಇನ್ನೊಂದ್ಸತಿ ಮಾಡ್ಬಿಟ್ಟು ಫೋನ್ ಮಾಡ್ತೀನಿ.
ಮಾಡಿದ್ವಿ ಸರ್ ನಿಮ್ಗೆ. ಎಸ್ ಮಾಡಿದ್ವಿ.
ಸರ್ 5 minutes ಬರ್ತಾರೆ.
Okay, sir.
ಶಾಂತನು ಮೇಡಮ್ ಬಂದ್ರು ಅಂತ ಕಾಣಿಸುತ್ತೆ, ಶುರು ಮಾಡ್ಬಿಡಿ.
ಯಾರ ಸರ್?
ಬಂದಿದ್ದಾರೆ, ಎಲ್ಲ ಬಂದಿದ್ದಾರೆ. ಮೇಡಮ್ ಬಂದ್ರು, ಶುರು ಮಾಡ್ಬಿಡಿ. ಯು ಕ್ಯಾನ್ ಸ್ಟಾರ್ಟ್. ಸಾರು ಬಂದಿದ್ದಾರೆ. ಯು ಕ್ಯಾನ್ ಸ್ಟಾರ್ಟ್ ದಿ ಪ್ರೋಗ್ರಾಮ್.
ಸರ್ ನೇಮ್ ಕಾಣಿಸ್ತಾ ಇಲ್ಲ ಸರ್.
ಸರ್ ಬಂದಿದ್ದಾರೆ ಸರ್. ನರೇಂದ್ರ ಗೋಪಾಲನ್ ಬಂದಿದ್ದಾರೆ, ಅಯ್ಯಪ್ಪನು ಬಂದಿದ್ದಾರೆ.
ಎಸ್ ಎಸ್.
ಸರ್ ಬಂದಿದ್ದಾರೆ, ಮತ್ತೆ ಇವ್ ಮೇಡಮ್ ಬಂದ್ರೀಗ. ಶುರು ಮಾಡ್ಬಿಡಿ.
Yes, sir. Respected dignitaries, esteemed colleagues, faculties, scientists, research scholar, and my dear student. We are here for the first national webinar on COVID-19 in association with Karnataka Science and Technology Academy, Indian Institute of Science Alumni Association, Research Foundation of India, Student for Development, Mentor X, and REVA. This first national webinar series is with the lines of creating awareness among the students, staff, common man, and that's why the topic chosen by our esteemed speaker is COVID-19 awareness for the commons, clarification with cautions. And we are here to create positivity among all the staff, students, and the fellow colleagues, friends, and family, so that we can overcome this pandemic and we can lead a healthy life very soon. So to begin with, I welcome our esteemed Honorable Joint Secretary Sir, Shri Shesh Narayan Sir, S. Shesh Narayan Sir, who is an industrialist, educationist, motivating, inspiring, and he is such a very simple person that he always inspired to promote all kind of activities which will bring all-round development of the staff and student. He is always committed towards excellence, and with his positive critics, positive attitude, positive motivation, we are always striving hard to go ahead and keep the logo afloat of Seshadipuram Educational Trust, which is established in 1930. I welcome on behalf of all the forums to celebrate this 91st year of Seshadipuram Educational Trust by our Seshadipuram First Grade College. I welcome wholeheartedly our Honorable Joint Secretary Sir S. NAARAAYANAN sir.
Thank you.
I welcome next our chief guest, Dr. GOPALAN NARENDRAN, who is the Deputy Director Medical of the National Institute for Research in Tuberculosis, NIRT in Chennai. He is a principal investigator for the STREAM trial and an experienced researcher with over 50 publications, with an average impact factor of 3.5 and age index of 22. He completed his postgraduate training in pulmonary medicine at Madras Medical College and completed his fellowship training at University of Alabama, USA as a Fogarty Fellow. He was the member of the Medical University Committee for MD Chest Curriculum in 2013 and received the coveted NASI Scopus Young Scientist Award in Medicine for the year 2014 for his contribution in research from the National Academy of Science, India, NAST and Scopus. I welcome you, sir, on behalf of Seshadipuram Educational Trust, Seshadipuram Group of Institution, Karnataka Science and Technology Academy, and all the forums, MentorX, REVOP, and Research Foundation of India.
Namaste, sir.
We are here with one of the very elite person who is Dr. S. Ayyappan. He is such a mentor, such a godfather to KSTA that he has chaired Professor of NABARD, Adjunct Professor Nias, former Secretary, Department of Agricultural Research and Education, and Director General, Indian Council of Agricultural Research, ICR, Government of India, Ministry of Agriculture, Farmers Welfare, President, National Academy of Agricultural Sciences, New Delhi, Atal Bihari Vajpayee Chair on Technology, Foresighting and Policy Planning, ICR NDRI Southern Regional Station, Bengaluru. Born in Alkere, Karnataka, India on 10th December 1955, educated at National High School, Bengaluru, National College, College of Fisheries, Mangalore, US Bangalore, and PhD in 1988. He is basically scientist, Central Inland Fisheries, Barakpur, Senior Scientist, Principal Scientist, Director, and he has shared so many positions like Chairman, Vice Chairman, Member of Governing Boards of WFC, ICRISET, SIP, IRRI, ICRDA for many years. And regarding the awards, he is DSC from 14 universities, Zahur Qasim Gold Medal, 1996 to 97, Special ICR Award, 97, ICA Award for Team Research for 97-98, Gold Medal, ICA Award for Team Research, and his award goes in, and at the end, I would like to tell that he was given the Sir M. Visveshwarya Memorial Award by KSCST in 2017. He has also received Karnataka Rajya Sabha Award in 2013, and he has got even J.C. Bose Memorial Award 2014. And he is a fellow National Academy of Sciences, India, Society of Nature Conservators, India, Inland Fisheries Society of India, Zoological Society of India, Association of Aquaculturists, Society of Biosciences, ICEP, Academy of Environmental Biology, Academy of Environmental Biology, Natural Institute of Ecology, and National Academy of Biological Sciences. His major research areas were fisheries, freshwater, and aquatic microbiology. So I wholeheartedly welcome our esteemed Professor Sri Ayyappan Sir, Chairman of KSTA, for making his valuable time and guiding us. I welcome also our one of my esteemed friend, supporter, motivator, Dr. A M Ramesh ji. He is now currently the CEO of KSTA. He has graduated from the University of Agricultural Sciences, Bangalore with BFC, Bachelor of Fishery Sciences, MSc Fisheries, and subsequently completed PhD in Aquatic Sciences. He has got fellowship from international trainings at International Agricultural Center, Netherlands in 2002, International Ocean Institute, Dalhousie University, Canada. And professional experience, he is a technical assistant in ecological monitoring, technical manager in tiger shrimp, research associate in ecological monitoring, consultant in tiger shrimp, joined the Karnataka State Remote Sensing CASRAX Bengaluru as a project scientist. Then he elevated to scientist technical officer at CASRAX, and then he joined senior scientific officer Karnataka Science and Technology. Then he became chief executive officer Karnataka Science and Technology Academy, KSTA, Department of Science and Technology, Government of Karnataka from April 2018. He is into implementation of science educational and promotional activities throughout the state, further supported the activities programs of Vision Group of Science and Technology, Bangalore Nano International Conferences, Karnataka Science and Technology Promotion Society in the initial stage along with the DST. And he has published many research papers, journals, and he has written many articles in newspaper magazines, both in Kannada, English, and attended many national and international conferences. We are so grateful that both of the stalwarts are here with us to support and jointly, along with SFGC, supporting the programs which will create awareness, promote science for rural as well as urban community in and around Bangalore. It will be not justifiable if I don't welcome our most beloved principal, Dr. SN Venkatesh, who is the pillar and backbone behind such programs, and he is such a motivating, simple person that at a one go, when he sees or finds a program is very useful for student and staff, immediately he takes meticulous points to see that it comes to its present shape. He is very humble, down to earth, very supportive, encouragement, and gives strength to all the student and staff. I welcome you wholeheartedly, sir.
Thank you, sir. Thank you.
I welcome all my dear colleagues, students, admin, staff, friends, colleagues for this program. So now to begin with formal inauguration, I invite our Honorable Joint Secretary, Sir Sri S. Sheshnarayan, sir, to give his inaugural talk.
Good afternoon, one and all. Everybody hear me?
Yes, sir.
Yeah. Respected chief guest for the day, Dr. G. Nagendran, scientist ICMR, NIRT Chennai. Guest of honors, Professor S. Ayyappan, Chairman KSTA and Chancellor CAU Impal. Dr. A M Ramesh, Chief Executive Officer KSTA. Principal Dr. Venkatesh, Professor Santanu Das, Assistant Professor Manjunath, Dr. M. L. Ashok, Prem Kumar, Professor Salma Banu, staff of SFGC, and my dear young friends. A very warm good afternoon to one and all present here. I am joining you all today to inaugurate the first national webinar series on COVID-19, awareness, common clarifications with caution. Friends, as you are all aware of the damage created by COVID-19 pandemic to the world in general and India in particular, it becomes very important for each one of us to follow the COVID-19 precautions, rules laid down by the government. This pandemic does not spare any age group. We have people who are devastated, and in fact, possibly the after effect of this devastation shall be more severe in the coming days for these families. People who have lost their near and dear all of a sudden, suffer a lot, and some being sole breadwinners of the family. Keeping in mind the society and the families of ours, we should not venture out unnecessarily and follow all the COVID guidelines laid down. Let us all join hands to fight this deadly pandemic disease by following the rules strictly. I once again thank the principal of SFGC for making me part of this wonderful webinar. Thank you.
Thank you, sir, for accepting our invitation and inaugurating the program. Now I request our chairman of KSTA, Sri Ayappan sir, to speak a few words and spread the words of wisdom.
Thank you very much. Good afternoon and greetings to all of you. And a momentous occasion for all of us. A joint effort by the Sheshadripuram Education Trust with the Karnataka Science and Technology Academy and a host of other agencies on a very relevant topic. Esteemed Joint Secretary of the Sheshadripuram Education Trust, Sri Sheshanarayan Ji, the Principal of the Sheshadripuram First Grade College, Dr. SN Venkatesh, Professor Shantanu Das, our colleague from the Sheshadripuram College, the CEO of the KSTA, Dr. A M Ramesh, the chief guest, the speaker of today's session, Dr. G. Narendran from the National Institute of Research on Tuberculosis, Chennai, and several other colleagues and student friends who have joined this meet. Thank you very much. Welcome to all of you. I join Sri Sheshnarayanji and Professor Shantanu Das in welcoming all of you and not taking much time. We have been in touch with the Sheshadripuram Education Trust and the Sheshadripuram First Grade College on several efforts, collaborative efforts over the years. It's always very enthusing to be together in these efforts. Professor Shantanu Das and Dr. Venkatesh make special efforts to see that our any of these webinar talks and other sessions that we are going through are relevant, concurrent, and reach a large group of faculty and students. So similarly, as was mentioned, an important topic, an important occasion, a series of lectures in this national webinar. And we are very happy to be associated, Professor Das. With these words, I once again welcome and greet all of you and wish you all safe time during this pandemic. And we should get over all this, overcome this pandemic in a joint effort. Each one of us is an important link in this effort. I especially thank Dr. Narendran, specialist in tuberculosis, for joining us from Chennai and giving his valuable time for creating this awareness on the pandemic. So from all of us, Dr. Narendran, welcome to you once again. Thank you very much.
Thank you, sir, for your short and sweet words. I now welcome our another guest of honor, Dr. A M Ramesh, sir, to speak few words.
Good afternoon, everybody. On behalf of Karnataka Science and Technology Academy, I welcome you all to this national webinar on COVID-19. Our Honorable Chairman, Professor S. Ayappan sir, Honorable General Secretary of Sheshadripuram Educational Trust, Sri S. Sheshanarayan sir, distinguished speaker of today, Dr. Narendran, Deputy Director ICMR, NIRT Chennai, esteemed Principal of SFGC, Dr. SN Venkatesh, my good friend, Professor Shantanu Das, and coordinating officers, Professor Salma Banu, Professor Manjunath, Dr. Ashok. In fact, we have had association with Sheshadripuram College for more than a decade. Shantanu, can you hear?
Yes, sir.
More than a decade, we have organized many programs like this. In fact, my friend Shantanu Das has been very enthusiastic in such organization of programs. With these few words, I wish the program great success. I, on behalf of KSTA, once again welcome Dr. Narendran to deliver his talk. Thank you.
Thank you, sir. Now, without further delay, I would like to request now G. Narendran, sir, to create awareness among all of us and solve the myths and come out with the realities and the facts by which we can all save the common lives and save the nation. Over to you, sir.
Am I audible, sir?
Yes,
and
sir.
is my screen audible?
Yes, sir. Yes, sir. Audible, sir.
I'm sorry, visible?
Yes, sir.
Yeah.
Yeah, thank you so much. I'm indeed fortunate and greatly indebted to you all for inviting me to give a talk. And thanks especially to Santanu sir. He has told me to keep it as common and as generic as possible. So my humble request to any one of you who is asking questions is anytime you are free to ask me the questions, but make it little generic. Don't ask about a single patient, how they have to be treated. The reason is most of the times when we take these classes, the others get misled when we talk about a very specific thing. So whoever is asking any questions, you are free to ask at any point of time, but try to make it very generic so that it is useful for others and others don't get deviated or distracted by these questions. My salutations to all the elderly and stalwarts in the field. I could see that from the introduction that most of them have come out with a very, very important message. This is not the time for blame game as it have been happening in the media. I'm sorry to say this, not that all the media are like that, but what is important is to shoulder responsibility. Each one of us take that responsibility and to work in unison to see that it was a really wonderful talk and message by all these stalwarts telling that this is the time for us to work in unison rather than looking at the mistakes. We learn, rectify, and make the blunders into mistakes, correct it and make it correct. So that is the idea or motto behind this presentation. So I am actually a fan of this person, our most revered Prime Minister. The reason why I am telling is, now most of the messages we get, I am not a politician, I'm a scientist, I'm a pulmonologist, and what I'm going to talk is not based on my organization. It's going to be based on my individual opinion as a pulmonologist. The reason why I'm telling is lots of things I will show you very shortly. India doesn't stand in the panic-stricken world as far as COVID is concerned. Once I finish off my lecture, you will understand why. Secondly, I would like to really congratulate and really appreciate my DG ICMR, Dr. Balram Bhargava, for his relentless work and tireless work. Dr. Manoj Murekar, from Director National Institute of Epidemiology. They have done wonderful work to see that the influence of pandemic in India is mitigated. I'm grateful to our director and thousands of frontline workers whom I have been in contact with, who give me the experience of how to deal with COVID-19, the law enforcement agencies, the other sanitary workers, and most importantly, my colleagues who are really working day in and day out and get quarantined without seeing their families for nearly days. I have done that nearly 3 times, where it's really it was a very difficult situation for us to just stay away from our families, but staying within the house. And grateful to Santanu Das sir, especially because this is the opportunity for us to actually tell the real truth about COVID-19. Because if you look at COVID-19, it's almost becoming like 5 blind men and the elephant when you look at the news, when you look at the way in which the messages are spread in media. Actually, we see that there are hundreds and hundreds of people who have said that I'm not now watching the news. I'm not now watching the TV. There is no oxygen available. There is no hospital bed available. So my part of this lecture, where I'm going to share my little experience I had with COVID, is basically on how to manage it at home with respect to precautions that needs to be carried out, and how you can, how the doctor has to interact with the patients when the patients are at home, so that the scarcity of beds, the scarcity of oxygen can be really reduced, so the appropriate person gets that care in the hospital. So how does it spread? As you know, there are 2 ways of spread. This kind of a picture is not something unusual in any of the states I know in India, and we still blame the government. This is the unfortunate state of affairs by the media, not able to understand that they can play a role in spreading positive messages also. Of course, they have started, some of them have started doing it. There are two ways of transmission. You say airborne, and then people become jittery. Why this is airborne? Then what happens actually with respect to airborne? If it is airborne, if you walk on the veranda of your house, it should be come to the next person in the next colony. It is not so. It is limited airborne, which people don't understand. However, it is airborne in a place which is having intense exposure where there is no circulation. There are two types of transmissions in the air. One is when there is an intense exposure where you do not have the proper air exchange ratio. So an intense exposure like a cough or something like that. The second thing is a constant exposure within an enclosed space. Like you see most of the AC chambers, wherever it is, whether you call it software industries, you call it five-star hotels, or you call it sophisticated corporate hospitals, where is the ventilation? That is where we need to be careful about. We have to create ventilation air exchange ratio for us to save us from the disease. The most important thing is India is a democratic country and we are not imposing these kind of things. So the most important humble request to all of those who see is try to correct our own brethren, our own citizens, telling them that please, you enjoy freedom and democracy, but at the same time, try to at least now develop civic responsibility. So this is the reason why I told I salute my Prime Minister. The reason is that there are recently, some of you would have read the report from the Lancet saying that India was boasting about its first control of its first COVID wave, but now they have plunged into disarray. Nothing like that. I want to refute that claim, because if you look at this, I am not a statistician, I am not an epidemiologist, but if you look at this, tell me it is not very difficult for you with the amount of mathematics knowledge I have. I was weak in maths, that's why I took medicine. You can see that the death rate as well as the case fatality rate is extremely low in India compared to others. Hence, where is the problem? Day before yesterday, I was listening to one of the doctors talking in the television. So he was telling, how many of you have got, a patient was asking the doctor, why there's so much of shortage of oxygen in our country? Why there's so much of shortage of beds in our country? Then the doctor very comically remarked, how many people are there in your family? He said 5. Now, what if all of them develop diarrhea at the same time? So in order to accommodate this, do you have 5 bathrooms constructed in your house? Immediately the man replied, no. Then he said, are you below the poverty line? No, sir. I'm a well-educated fellow. I earn nearly 8 lakhs per month. But even then, why do you have only 2 bathrooms? You should have had 7. Now, this is basically the thing. The basic problem is it takes some time for us to come out of the pandemic. This is what people should understand and should not go into kind of a knee-jerk reaction, panic-stricken, trying to create scare among others. So when I finish this, you will understand the glory of our Matrubhumi. Now, what we need to know about this disease is that I'm going to talk very much fundamental things. Most of them will be known to you. So please bear with me if in case it's repetitive for you. So all that you will see is that the symptoms do not start early. So this virus is a very peculiar virus. So it has many properties which are not at all unique to any virus, which is natural. I don't want to comment much about. I have told very clearly, I'm not here for controversies. So if you look at that, usually if you take the coryza virus, there is a rhinovirus which causes the common cold. The patient, any patient or index case, the first patient who gets infected with the common cold throws symptoms, you will see that the fellow will have a running nose. And when he starts having sometimes having fever, and after that starts, then the virus starts spreading to others because of fomite spread or any other spread. If that person is asymptomatic, you don't see the other guy trying to get into problems. Here, the problem is the virus spreads from one person to another even before the index case or the first case in the family develops symptoms. This is what many people don't understand. This is the cause of a lot of family members being segregated or quarantined, even without counseling them, so that they themselves feel that If they are older people, they feel neglected. If they are the youngest, they don't understand or realize this. So it doesn't mean that you have to strictly quarantine them at home because your transmission has already occurred. But then how do you take precautions? I'll come to that side by side. So initially, the RT-PCR becomes positive after you start developing symptoms, and it differs with respect to the first and the second wave. In the first wave, it was 5 to 7 days, after which if you do an RT-PCR, it used to be positive. Initially, it used to be negative. And there were rumors that RT-PCR can be falsely positive. No, not at all. It is like getting stricken by lightning twice on the same day. So the chances are very low that somebody is RT-PCR positive and not having the disease of COVID. However, it can be that RT-PCR can be negative, but the still person can have COVID. That is where, if you can see my cursor on the screen, in the incubation period, or after the antibodies develop, you can see that the RT-PCR, the viral load levels come down. And there is a common notion among everybody. They mistake the CT scan, the computer tomography scan, to the CT threshold of the RT-PCR detection. Now, you are much more familiar with polymerase chain reaction than me. Very simple that the more number of amplifications done by the machine, the less is the viral load. So if usually when we get it at 18 or 20, you have a very high viral load. But still, we are not very clear whether this actually causes the problems with COVID disease. I shall tell you why. So the therapeutic targets, if you see, I told you, initially it is caused by the viral response, and later it is caused by the host inflammatory response. This is how it goes. So you have the host response here, the viral response here, and the host response here. This is what everybody should understand. The reason why I am telling you is, it is not the virus that causes the damage at the end. It is your own immunity against the virus. It is simply like, I am giving you a very common example, like a mosquito sitting on somebody's shoulder. You give a huge blow to the shoulder. It is not the mosquito. It is actually your friend's shoulder which gets injured in the same way. The most important thing which I want to emphasize, especially for people, non-technical people, is that little knowledge is more dangerous. I put this slide basically because most of the times we doctors get a message saying that these are the medications we have taken. What should I do next? Then I was really puzzled with one of my staff. I asked him, I have never seen you, or you have never spoken to me over phone. Then he said that, no, the other staff whom you treated actually gave me the medicines. This is a very, very common practice in India. Again, if you look at people, they will say that what are the drugs? Let's say a diabetic for 20 years, he'll be much more experienced as not only as a patient, but he will start instructing what drugs to take for the next diabetic, not knowing the physiology. This is a very, very dangerous trend which is occurring nowadays, which is the actual cause of people getting into delayed diagnosis and delay in initiation of treatment. So first wave symptoms and second wave symptoms, there is a minor alteration. In fact, there are lots of other major alteration also with respect to the first wave and the second wave. Who is vulnerable? We have found from our own observation in Chengalpet Medical College through my collaborator, Dr. Sumati and Dr. Vasant in KMC and Dr. Vinod Kumar in Stanley. There are lots of medical colleges where they have said, and we have found out that hypertension is not a big problem. It is diabetes. And you know that India is a hub of diabetes. Uncontrolled diabetes is one of the common reasons, and this is the reason why people get into problems. Diabetes with hypertension, which is due to, as you know, due to the coagulopathy of diabetes itself, increases the risk. Diabetes with kidney injury, that is those who have compromised renal function, are the maximum people who get into trouble with COVID. This was with respect to the first wave. Secondly, old age people were vulnerable in the first wave. Thirdly, we definitely see some advantage with patients, asthmatic patients over COPD patients, probably because smoking reduces the immunity of the lung. Again, TB patients, we don't see so many cases of TB infected with COVID. we don't see so many cases of HIV infected with COVID? The answer is very simple. It is because their immunity is not able to fight the virus. They just keep quiet when the virus passes on. I'll give you an example. Let's say some rowdy is there in the street and he tries to snatch the chocolate from a child. The child starts crying. It doesn't retaliate. So the injury to the child is not caused and it goes away. But the same guy comes and meddles with you, trying to snatch your purse. Then a fight ensues. And that is basically the reason for the damage occurring to all the structures, including the lung, the heart, and other places. Then what are the symptoms that should alert you to take medical consultation? I'll come to that. Now, these were the symptoms during the first wave. Blocked nose, swollen sinuses, tenderness, congested conjunctiva. We didn't see so many cases in the first wave, but we are looking at them in the second wave. I will be overlapping between the first and the second wave because of the want of time. Nowadays, in the second wave, it starts with headache, chillness, somebody telling that they're unassumingly, the temperature may be normal, but they're saying, I'm feeling very chill. You please switch off the fan. You know that now this is summer, at least in the southern aspect of India. So with this kind of a summer, suddenly somebody tells you, no, switch off the fan. I feel really chill. Then again, you have to suspect COVID. A hacking cough, I'll come to that later. Muscle body pain has been a uniformly consistent and persistent symptom of COVID, not only COVID, even vaccination due to COVID. And when you ignore these symptoms, you develop shortness of breath. Lots of people are actually panicky, thinking that the day they get COVID, they are totally asymptomatic. Suddenly they drop down with shortness of breath. No, it is a gradual phenomenon which you can perceive using your intelligence. This is not something very difficult. The reason for me to stress on this is most of the panic happens because of your own stress. You get rush up because there's a COVID positive result. You frantically start calling doctors. You may not be able to reach them over phone. Then the stress levels increase further. And then you go to a hospital. The hospital just discriminates you as saying that, no, this is non-COVID. You have to go to COVID. Then you go to the COVID. They say there's no oxygen bed available. Why do you require an oxygen bed immediately? So this is basically the crux and preamble of my presentation. The last thing which you need to know is, which is common between the first wave and the second wave, is that unusual abdominal symptoms. Patients have some kind of an abdominal discomfort, repeatedly going to the restroom without any heavy meals or non-vegetarian meals, something which can usually disturb you. Unusual way of hampering, a fullness of stomach. These are some unusual symptoms, but you can be free. You can be relieved that those kind of symptoms, when it doesn't start, you don't develop saturation loss, because problem is occurring in your gastrointestinal tract, not in your lung. So I don't want to go into the further complications with respect to extrapulmonary manifestations. Now, what about the symptoms you need to be afraid of? Now I'll come to the second wave. Now, what are the differences in the presentation of the first wave and second wave? I used to say running nose is not a symptom of the first wave. We have never seen patients with running nose. It's usually a stuffy nose. But here, the reason why I'm stressing this point between the first wave and second wave is, it is a problem for medical officers, doctors who attend to you. If you have a stuffy nose, we used to call you COVID in the first wave. And if it's a running nose, we used to think that it's just seasonal flu. Now, rarely, we are seeing that COVID cases also have a running nose initially, especially after the phase of headache. And this actually has caused problems with clinical diagnosis. But patients developing breathlessness, it is usually not the first symptom to occur. This is what people should understand. That is why when each one of you are in the lockdown period, you are very close to each other. Please talk to each other and try to arrive at what is your normal behavior and normal system, which the other person needs to know. It's very common for the husband or wife or father or son to immediately say that something is going abnormal in my spouse or my relative. So it's not very difficult to find out. You are the best doctors available at home. So the reason for me to stress on the point is breathlessness does not strike you suddenly. It is because of you ignoring your own symptoms. Most of the times it's a light cough or a light a nasal stuffiness or a light headache, which is being ignored. Then how do I then give importance? When do I then give importance? The easiest way is the pulse oximeter. I'll come to it later. Secondly, the problem of infectivity with the second wave is so high that it doesn't leave you with just one person. Previously, we used to see 1 or 2 from a family of 10 or 11 getting into COVID. But now we see almost the entire family getting into COVID, but not all of them with the same amount or extent of severity. Fever for more than 5 days is something which you need to investigate, especially in a country where there are lots of endemic diseases as in India. We have seen dengue resembling COVID because of thrombocytopenia and body ache and everything. We have seen malaria doing that. We have seen seasonal flu doing that. So the basic reason for me to take this class is not to make you doctors self-sufficient so that you don't have to listen to any other doctor, but to be aware of what is happening and tell the doctor precisely what you are suffering from. That is the basic idea of this lecture. Comorbidities, as I already told, we are seeing very selected comorbidities as the cause. The second wave does not stop with old people. In fact, we have seen old people having a better recovery than younger people because of their immunity is little low. So they don't fight the virus. They allow the virus to keep sitting on the lungs and then they pass away. So, but doesn't allow the elderly people to turn into a fatal disease. This is what I want with the second wave. The first wave indeed was really detrimental for the old age because we never knew how it was going to progress and how it was going to. We have enough evidences, scientific evidences generated both globally as well as in India. Advances have occurred in this field. So it is not very surprising for me to say that you don't have to be worried about. Uncontrolled diabetes, obesity still remains a huge problem. Each of you should try to do some minimal limited exercise at home. This is really a problem for diabetics because usually they love walking on the roads, other thing, but because of the lockdown and restrictions, really it is really a problematic thing for diabetics, especially control of diet as well as catabolism of whatever they have taken inside. So the metabolic energy which is required to be wasted or required to be worked out is not possible now. Hypertension per se, you don't have to be worried about, irrespective of whatever treatment you are taking. The previous notion initially was that patients with ACE inhibitors or ARBs, we call it, as the separate group of angiotensin converting enzyme inhibitors and receptor blockers and all these things. Now nothing. Any antihypertensive you are taking is well and good, doesn't prepone you to COVID. Again, patients on prazols, that is the omeprazols, rabiprazole and esomeprazole, all these prazols, they thought that yes, it increases COVID tendency. Of course, now it is controversial, so I'll not touch upon this, but ranitidine is a very safe drug when you're taking other drugs to satisfy your stomach with lesser gastritis. The other thing we saw with the first wave was happy hypoxia, which was much more dangerous. That is, suddenly patients develop hypoxia when they are just go to the restroom and come back and you see that they are starting breathless, but other times they are just very subtle and they manage. But when you go to the hospital and they put the pulse oximeter, they see that the saturation is extremely low, and they have a very poor prognosis because they go in for a sudden cardiac arrest. This is what we saw in the first wave. Nowadays, we see symptomatic hypoxia. I don't know which crazy fellow gave this name as happy hypoxia. In fact, it is a melancholy hypoxia, which I would call it. Something called orthodeoxia. People say that is also another common feature of extensive COVID, where the person will say, I'm not happy sitting and talking with you. Let me lie down. So if they say that it is hypotension and hypoxia together, and so that kind of a thing again should ring bells in your mind. Exhaustion after attending ordinary things like nature's call, especially old people, they start this. They say, I'm feeling, I don't know, I'm feeling really exhausted. I'm just coming from the toilet. I'm not able to understand something difficult. Tachycardia. Usually when your heart rate, even during anxiety, may reach up to 100, not more than that. You can't say that the guy is really tensed up. Except probably when you have your exams or your Viva OC, your heart rate doesn't go up to 100. Beyond 100, it needs to be tested. You need to show yourself to your doctor. Then those who start with diarrhea and vomiting, they actually have a better prognosis in the second wave compared to those in the first wave. In the first wave, there were problems with electrolyte disturbances also. If your chest X-ray shows findings, that means your CT will definitely show findings. That means you are having some extensive disease. So these are some of the alarm bells or control signals which you need to be careful about. More ominous signs, if you see feeling of chest tightness, I am not able to have a deep breath. This has to be differentiated from what is called sigh breathing. Patients who have COVID disease, usually they say sometimes they'll say, by taking a deep breath, I feel little relaxed. So that kind of a thing is very common in COVID. That doesn't cause panic. What I mean to say is somebody, just like myocardial infarction, there is heart attack, somebody sitting on my chest. Now I'm not able to expand my chest at all. Again, giddiness while straining. I go to the restroom, I feel giddy. I suddenly get up, I feel giddy. Shortness of speech, it can be easily found out by family members. You don't require a pulse oximetry to see somebody is breathless. You say, the person starts talking, you talk to him, you say, actually, I want to actually. So this kind of speech where they are not even able to complete their sentence, and it is interrupted by cough or by breathlessness, very commonly you put the pulse oximeter on a hand to check the saturation will be low. This was a short this thing which was told by my cardiologist when after attending to a COVID case, I developed very severe palpitation. I don't know still what is the diagnosis. He used to say, where is your house? I told I live in the second floor of my flats. So if you are able to walk twice up and down, that means you are not having any cardiac disease. That's a rough rule of thumb. So I used to inculcate the same thing to my friends, saying that if you are able to walk 2 times to 2 stairs, then don't be worried about any saturation. Then certain people, very strangely, they say, like I had one of my friends who was a flute player. He said that I'm not able to play my flute. You can imagine what will happen to what you call a Nadaswaram player or somebody using a very heavy piano or something like that. Again, certain singers have told that they are not able to go to higher pitches and all that. So these are subtle changes which you have to closely watch. And very commonly, older people, they used to say, I'm not able to play with the kids. I used to do that with because nowadays, because of the want of time, life has become so mechanical. It is not the parents, but the grandparents who actually spend time with their children. And it's really unfortunate if you have a nuclear family where you do not have that kind of a pleasure for your kids available for your kids all the time. And this creates a very good, I have seen that those people where both the parents go for work, the children are really stressed and they develop lots of psychological stress now because of the problem. The last one is bedwetting among old people. These are subtle changes to say something wrong is going on in the family. What I mean to say is not usually used to doing it. This is because of tiredness and exhaustion. Especially older people, they don't, even a young person for that matter, if they start bedwetting, that goes to show something is highly abnormal on that. Now, caution needs to be exercised while making a diagnosis, because by knowing all these things doesn't mean that you can diagnose COVID, or because there are lots of other differential diagnoses. So it's best left to the doctor to make all that I'm saying is you be aware of these symptoms. That's all. And then tell the doctor, whoever is treating you, these are the ways, these are the things which is happening newly. Am I having it or not having it? Obviously, it will be the RT-PCR and the CT which can decide whether you have COVID or not. Age related, of course, I told you that old people in the first wave were affected, but now because of the vaccination drive, thanks to the entire, any government agency as well as the NGOs and the private hospitals, everybody has started this. Now the age group of affection has come down. We know that vaccine is the only way for us to protect ourselves against mortality. There is a wrong notion going on that one odd fellow got this problem, one odd fellow got that problem. It is very, very important for you to vaccinate for the only reason that the mortality we see is very low and the severity of and the hospitalization need is drastically reduced with vaccination. Whatever may be the vaccination, don't worry about it, because there is no, you need not be too particular about what is the efficacy as told by the media, that 98.3 and 98.276. Don't bother about it. Any vaccine you take helps you to protects you against severity and hospitalization. Please drive this message. If this message is driven, I'm very happy that my goal is achieved. Stress leads to lots of overlapping and overwhelming symptoms. As I told you, it can cause hypertension. It can increase your diabetic levels. So the most easiest way for you to bring down stress is to meditate. Think about the Lord who has created you. And most importantly, Swami Vivekananda used to say, atheists are those who do not have belief in themselves. It is not in God. So what I'm saying, even to the atheists, is to at least believe in yourself and then stay calm. Try to meditate, try to have social gathering with your own family members now that you have a lockdown, even though it is not easy in all cases. Have food together, because this is the time in which stress comes down. If you have sleep disturbances, it can be due to COVID or can occur with post-COVID as a post-COVID complication also. I have already covered about endemic fevers. So what are the signs of recovery? When do you, if somebody has COVID, when do you say the person has recovered? Easiest in the initial wave was anosmia and ageusia. Even now, it's surprising to in the second wave that we do not see much of anosmia and ageusia. But whereas previously we used to say, my colleagues are there, Dr. Vignesh and Dr. Thirumaran listening to me, they will easily say, we used to dismiss a patient who says anosmia and ageusia in our first wave. We used to say, okay, you're recovered, don't worry about it. But now we are able to see that not only is the incidence of anosmia and ageusia have come down, but also we see that despite the partial anosmia or ageusia, still that certain people have limitations in or involvement of the lung. Malaise without fever, again, is a sign of recovery. This is very, very important. That's why I told that if you have fever along with malaise, it is natural. That means the disease process is still not end. But if you have only exhaustion, you don't have fever, that means in most of the instances, you have a better recovery with the first wave. We still do not have concrete evidences how it goes in the second wave. In the second wave, two things we have seen very commonly. If you start developing cough, but it is not associated with breathlessness, your saturation is normal, and you start developing a hacking cough, that means you have slowly recovered. Your recovery phase has started. I told you the recovery inflammatory phase, and then you have the recovery phase. Again, very, very surprisingly, in the second wave, we see that these people produce tenacious sputum. They say that, yes, now I'm all right, but after that cough, now the cough gets relieved and you start throwing sputum. And with this sputum, the recovery phase starts. So these are the signs of recovery. Post-COVID symptoms, I told, exhaustive pain all over the body. That malaise is really, we used to call it chronic fatigue syndrome. It's very common. Muscle ache, cough cramps, all these things are very common post-COVID symptoms. And again, lack of concentration and insomnia, we are able to see. Some of them developed subacute thyroiditis, but this was much more in the first wave. In the second wave, we could not look into that. I don't have experience on that. Cutaneous lesions are very common in the second wave. We are able to see people with sudden urticaria. Then later we find out it is due to COVID. Hypotension and tachycardia per se is not a common feature of COVID, which means there is some, what I'm saying is not a feature of COVID recovery. It means either the patient is going for some cardiac complications together with COVID or because of COVID. Again, patients who recover from COVID also may have some kind of an orthodeoxia. Orthodeoxia means they say, I better lie down because if I stand, I really feel a little hypoxic. This has occurred with many of patients even after 2 to 3 months of COVID infection. So I already talked about the second wave symptoms, how they vary. Age group now, any age group can be infected. The acceleration of phases have started with this. That means initially in the first wave, we saw that first 4 or 5 days, the patient was all right. That is, the patient was asymptomatic, not throwing any symptoms, and then started developing symptoms. But now we see very clearly that within a short period of span of time, they develop symptoms, and then the infectivity is extremely high. That's where we have to be careful about, even at home. So what are the high risk groups? As I told you, the high risk groups remain. Old age is a high risk even now. Obesity is definitely a high risk. Diabetes, most important is diabetes with hypertension or diabetes with acute kidney injury. Chronic kidney injury also is a problematic condition with COVID. Those who are having fever for more than 5 days, again, this is a warning signal. In fact, I should not have put it in the high risk group. It's a warning signal. Again, CT scan showing bilateral lesions and malignancy, both patients with active malignancy diagnosed and those on post-malignancy treatment, both of them on chemotherapy, they are also vulnerable to COVID. Now, what to do when a patient is found to be COVID positive? This is where our knee-jerk reaction begins, our anxiety starts, our adrenaline starts pouring out of our body, and then we start terrifying the patient, we start terrifying ourselves. That's the way it goes. So this is where you need to consult your doctor and discuss with him. The biggest problem that occurs which causes happy hypoxia or patients developing sudden desaturation is because you think you are having a mild problem. You don't discuss with the doctor. And the other thing is self-medication and pharmacy giving you drugs without any prescription. This is a very common finding which occurs. The basic now thing is nobody gives a prescription. Even the doctors, when you consult, they send you the prescription by WhatsApp and then you go and buy it. The reason is, unless the physician who is treating you knows the baseline parameters, what is happening to you, he cannot suddenly diagnose any disease in you. This is very, very important. This is very, very important. So the second thing is assessing temperature. Assessing temperature and saturation. This should be done on a regular basis, at least 3 times in a day when a patient is, whether his patient is asymptomatic or symptomatic. The reason is most of them are mild, self-limited disease even now. The reason for you to do the test is to take precautions. Now, most of the times when we say it is self-limiting, people totally avoid medical attention and then they say that I'm all right, I'm doing well. No, that is not the reason. You have to go and test yourself for RT-PCR for the sake of your own family members so that others also can take precautionary measures for the sake of your neighbors, your relatives, everybody at family, at home as well as at work. The other thing is, anything about 95, you don't have to worry. It's not that all patients will land up with hypoxia and then you drop down dead on the road. It is not like what is being shown in the pictures. Unfortunately, that is not the status. That is the status of a neglected person, neglecting his symptoms and signs, neglecting or avoiding the consultation of a medical officer. That is where it starts. Maybe 1 odd person out of 1 lakh may have this because, as you know, medicine is a science of uncertainty and art of probability. This is what William Osler said. So it doesn't mean that it should not happen, but that occurs, as I told initially, a person who are being struck twice by lightning on the same day and the same hour. So that's a that's a rarity. It need not be focused again and again in any of the media for whatever reasons. This is what it really shakes, because the government is taking enough action and we are a huge population. We are almost 2 billion, mind you. It's not very easy to cover each one of them within a single day or within a single shot. And then what you need to do is prepare yourself for hospitalization. So what are the lab investigations we usually do? Why should we do that? Most of the times when you consult the doctors will say, you please do there are basic investigations like plasma sugar to see what is your sugar level, liver function, renal function to see if they are all normal, because a person with a there is a slight derailment of liver and renal function test in COVID, even in normal person. It doesn't mean that you can just brand them as jaundice patient or brand them as kidney patients. Slight derailment is possible. Small, very, very simple non-specific tests like the total count and differential count really helps us to find out. I'll come to that later because that is one of the markers of prognosis. Hemoglobin to know your anemia, because very severe anemia with hypotension, your pulse oximeter itself will not work. A lot of patients are developing platelet count decline as well as lymphopenia or neutropenia. This is very common now with the second wave. We didn't find that amount in the first wave. If you look at what are the specific lab investigations, as you know, one is RT-PCR, other is the rapid antigen test. Both of them are equally good on a surveillance point of view, but the gold standard is RT-PCR. Of course, I told you, if you got seen the initial figure, what I told you, in the asymptomatic period and after the inflammatory phase, the RT-PCR will be negative, which does not mean that the patient is COVID negative. However, if the RT-PCR positive, you don't have to suspect the test at any point of time because they are all well standard tests. And you are also to look for surveillance of complication, that is looking at the biomarkers. The biomarkers depend on the stage of the disease. Usually in the stage of infection, you have something called a relative lymphopenia. Your lymphocytes come down. That really scares some of the people at home because they think that, okay, my count is low, as if they have taken some anti-cancer therapy, their counts are low. What should I do? It's transient. In most cases, you recover fully. And then the inflammation starts. Then you look at the inflammatory biomarkers in the form of CRP. Ferritin initially was looked into, but now we see that ferritin doesn't give you much of information regarding prognosis. You don't have to go and look at your IL-6. Again, LDH may be elevated, AST/LT may be elevated. For clotting, the most important is D-dimer. We know now that COVID is a microvascular coagulopathy, which is causing the problem in the lung. The lung is like a sieve. The respiratory membrane gets thickened because of coagulation followed by inflammation. The entire thing, like a filter, the filter is now blocked. Then the oxygen doesn't get penetrated into your artery, into your blood vessels from the lung, the alveolar tissue. That is the main problem which is occurring. So it is not a ventilatory defect. It is not that you require ventilators. All that you require is something to push your oxygen into the blood vessel. Again, cardiac troponin, we are not looking into. Tropi, we are not looking into now because we know that it's too late a condition and that you cannot do it at home. You have to be hospitalized. The next thing which you will always see is the CT scan. CT scan has become a very, very valuable diagnostic test even among patients with RT-PCR negative. This is the truth. The only thing is you should know when to do the CT scan. If you do not know when to do the CT scan, then it is of no use. Just like RT-PCR, you do it very early. You almost miss the diagnosis. But if you do it too late, it's only a question of evidence creation or evidence-based medicine treatment, but nothing else because you can't do anything about it. I'll come and show you. I will make you masters of reading CT in a few minutes. There are two things which you usually come or encounter when it comes to HRCT. And mind you, what you are doing is a low dose HRCT. That means the radiation is low. So for me to know how sure it is corona, let's say specificity is the CORADS rating. The CORADS rating does not show the severity. Most of the times you have a CORADS rating of, let's say, it goes from 1 and 2 are actually ambiguous. From 3 it starts as possible. 4 is probable, 5 is definite. And interestingly, RT-PCR positive puts the person as CORAD 6. So it doesn't mean that the lung should show anything, but if you say CORAD 6, that means the person is RT-PCR positive. So it increases the accuracy of corona detection. So CORADS has got nothing to do with severity. Some of them see the CORADS rating at 4 or 5 and then immediately start pouncing that, yes, I'm now down and I'm going to meet God in heaven in the next 2 hours. No, not at all. What is most important is how much of lung is damaged. What is the extent of area of involvement? That is actually given by the CTSS or CT severity score. And each of them, radiologists have a different score. Usually, the score starts with points. You say 5%, 5 to 50, 25%, 25 to 50%, and you have points 1, 2, 3, 4, 5 for each lobe. So there are five lobes: right upper lobe, right middle lobe, right lower lobe, left upper lobe, and left lower lobe. There is no middle lobe. So 5 into 5, 25. Out of 25 points, how much is my score? That means how much of lung is involved. You say 18 by 25. That means 15 by 25. That means almost 60% is involved. 20 by 25, 80% involved. So the severity of lung involvement, which decides on your life, is given by the CTSS score. So what then the other important jargon which you would have come across is something as ground glass multiple ground glass opacity is seen, multiple ground glass. What is this multiple ground glass opacity seen? And then suddenly then they'll say consolidation and fibrosis. Just to give you a small figure, you see this is the normal lung, which is totally black. It's not totally black. It is interspersed with. I am making it as simple as possible. So don't think that by knowing this, you know about CT scan of the lung. Obviously not, because then my job will go. So then what happens is when this black tissue is replaced by some kind of a gray or semi-gray blackish one, we call it as ground glass. For us, in a technical manner, for doctors, we used to say that if you are able to see this gray and you are able to see vessels cruising through, it is ground glass. If you are not able to see vessels, there's complete opacification in a white color, then it is consolidation. But then what happens is it becomes fibrosed. What I mean to say is like a reticular network, like a fishnet with entangled with fishes like that. The uniformity is gone. This is the end stage lung disease. This is how it progresses. Now we'll look into the CT scans. Now I was telling you about ground glass. You can see here that this is normal lung. You can see here that from here, you can see that the black is actually replaced by some kind of grayish hue. The same thing here. So this is what we call it as classical ground glass. Then what happens is, as the ground glass progresses, you say it becomes white. You can see here that it's almost white. That is a feature of consolidation. That means the ground glass already turned its consolidation. You can see here, this is consolidation. This is not ground glass, this is consolidation. That is, you can see that it is not gray, it is almost white. And then I told you this is the Korat score. And then what happens is they become fibrosed. I'll show the CTs. Now this is from one of the patients. We don't do CTs immediately. The other biggest mistake which is being committed currently, I don't want to mention that who is the reason for it. Half of this is patient induced, half of this is physician induced. So we cannot blame anybody. Now, as I told you, this is not a blame game. This is not a fault finding mission. This is for us to work in unison. The CT should be taken at least 3 to 4 days post symptoms. The more asymptomatic the patient is, the more time you can spend trying to avoid taking a CT scan immediately. What I mean to say is, if your saturation is maintained with a pulse oximeter, you please don't rush up and then start taking a CT just because you are found to be RT-PCR positive. It doesn't help you because it takes 5 or 6 days for us to see if the lung is involved. So this is one of the scans taken on the 8th day of the patient. The patient was symptomatic for 3 days with fever, and then later his fever subsided. So these are signs of recovery. The patient was carefully monitored, saturation was maintained. All that you will see is you can see some kind of a grayish thing which puts the Korat's rating as almost 3 or 4. But the patients, I'm sorry for the noise, I could not edit it. Now this patient had almost a normal CT of the lung. This is again another patient whose CT was taken almost on the 10th day when he said he has breathlessness. His saturation was maintained. This CT was not ordered by me. This CT was ordered by the patient himself. This is what happens when you do it without medical consultation. I only told that you have wasted your money and your time because I never asked you for this. You may ask me, then you say that what determines whether somebody should take a CT? That's a very big, very important question. The biomarkers. Without biomarkers, if there's no raise in biomarkers, if very, that is again, it's going to be a rare chance where you see 2 suns and 2 moons. for you to have a sudden desaturation. So if your biomarkers, mainly CRP and D-dimer, the CRP looks into your inflammation and the D-dimer looks into your coagulation. So you have coagulative problems with D-dimer, where you have to give blood thinners. And the problem of steroids, I'll come to it later, will be based on CRP. If the CRP levels are normal, you don't have to worry about steroids. Now, this is another patient with moderate COVID. Here, this patient had CRP elevation. You can see that's almost 250. Normal is around up to 20. But in mild cases, it goes from 20 to 50. But others, it goes beyond 50. Now, I'll show you exactly. You can see the ground glass classically there. You can see, and these are all peripheral lesions. Mind you, you have lesions at the periphery of the lung. I'll come to it why I am stressing on this point. You can see here. Again, in the periphery of the lung. Now, this patient had to be put on steroids. And these are late lesions where the lung has been destroyed. Now, what you see is not the functioning lung. It is nothing but, let's say, a paper that has been burnt out. Now, this will not function and the patient develops very severe lesions. Now, you can see one of the advanced cases with hypoxia. Now, what you are seeing is the fibrosis. You can very well see here the fibrosis. Now, this is consolidation and this is fibrosis. This is not ground glass, which means almost it's a burnt out lesion. Now, sometimes patients come with ground glass. This is again ground glass where you don't see, you can see that the air in the trachea is black. The color or the complexion of the lung should also be of the same color, which is not. You are seeing it as gray. Now, this is a case of congestive cardiac failure. The reason why I'm telling is the difference between the two. You could have seen in the ground glass, everything is occurring in the periphery. You can see that they occur at the periphery. But whereas here, there's uniform, there is uniform ground glass. So that is why you require an expert to decipher what it is. Coming to the most important point, if you ask me, tell me one thing which I will purchase as a precautionary measure, the one most important thing is pulse oximeter. And India, no need to say, immediately when you say that we require something, the prices of pulse oximeter, that commodity goes up like skyrocketing levels. So the pulse oximetry, when used to buy it, was something which is a neglected thing. They say, why should I measure the saturation? It's almost going to be maintained. It was 700 rupees before the COVID first wave. It became 1,500 rupees in the first wave, and the second wave now it is almost like gambling. Like for an air ticket, if you want an air ticket to try to travel today, you will have the same skyrocketing prices. In the same way, a pulse oximeter is now costing 4,000. Even then, I would suggest that if you can buy it, it will be well and good. But again, people don't know how to read or use the pulse oximeter. So that is where you need to be careful. The first one is that you have to put the pulse oximeter in the middle finger of your dominant hand for the best results. This was something surprising because even when we are trying, initially we were thinking that it was the index finger of the dominant, but usually there's a subtle difference. There's not much difference between the two, but usually the middle finger. But don't ask me if somebody doesn't have a middle finger, you can always use the index finger. The second thing is wait for the person to stabilize. That means if a person is, especially old people, they have what are called intentional tremor, non-intentional tremors. If somebody is moving their hand, or children, they are moving their hand, you will have abnormal values. So again, don't get panicky about it. Thirdly, distract the patient and not ask the patient to see what is there in the pulse oximeter, unless unfortunately the person is alone at home or something, or you have quarantined the patient, they have to see that. I used to tell my patients in a different way. I used to tell that sit in calmly, close your eyes in front of the mirror and then look into the mirror after 2 minutes to see what is your saturation. So stress levels will again fluctuate. Most important, especially for ladies, please take off the nail polish or any other dye in the skin. Secondly, there should not be any movement. That is extremes of ages. You have to be very careful. Thirdly, most common thing is the battery winds are very fast sometimes. So check the battery is low, because all these things have created panicky among patients, and they have called up in the middle of the night to tell that we are not able to see it. And most of the times it is easy for you is titration. Titration doesn't mean you have to send it to the best of engineering colleges or hospitals like your institution to titrate. Just ask somebody who is normal. And that is the value. What I suggested is hereafter, all of you for some time, try to note your values 3 times a day when you are normal, because that gives us the baseline, what your actual value is. The reason is that saturation is also to some extent age related. You cannot expect a 90-year-old to maintain a saturation of 97. They usually they are able to tolerate hypoxia well than an youngster having the same thing. So their saturation may maintain somewhere between 93 to 95. But anything less than 92 deserves to be seen by a doctor if the person is extreme of age. But what I'm suggesting is that is the reason why old people, if they are normal, no harm in trying to get the record the saturation initially, so that you know what happens, how much it has gone down, because we should not be under the impression that it has gone down from 99 to 92. Again, if you have walked 2 stairs or you have been doing exercise or something like that, usually the saturation doesn't get affected too much, but you have to allow for some time to cope up. Anemia per se doesn't reduce the saturation, but anemia with giddiness or hypotension can reduce the saturation. Of course, there are certain strange drugs like doxycycline. There are some anti-cancer drugs can reduce the saturation because of changes in the nails. Again, when you are using the pulse oximetry, if certain people got onychogryposis or something, or got ingrowing toenails, other things, don't try to use the other finger in these instances. I told you the easiest way to see whether this pulse oximeter is working is try to put it on somebody's hand who is not having symptoms and see. Not a bad idea to have a baseline saturation levels noted for, especially for the elderly. Anything less than 94 is an ominous sign. I will tell you why. Again, if the heart rate is too high or heart rate is too low, again, you have to be little careful. So coming to that, how does a pulse oximeter work? Just because you are all scientific community, all that is, you have 2 kinds of signals. One, a red signal. If you look at it, there will be a red light which is coming up. The other is the infrared light. These are the 2 lights which actually go from a generator to the sensor. And oxyhemoglobin and deoxyhemoglobin behave differently. So if I show this, it looks a little complicated, but I'll make it very, very simple. This is the saturation level. As the saturation increases, the red light is not observed, but the infrared light is observed. Whereas if the saturation goes down, the infrared light is more observed, the red light is not observed. So all that, this reference is calculated, and by that you have a saturation, which is shown in your pulse oximeter. So this is the saturation level of 98. And you also see, if you are experienced enough, you can also see the regular rhythm coming up. Now, why is it critical that the ICMR guidelines say anything less than 94, it is severe, you require hospitalization and all that? The reason is that whenever, this is the oxygen dissociation curve, if you see that as it dips below 90, the partial pressure of oxygen in the blood goes down drastically. Here you can see that it's almost up to 90, it is almost horizontal line, but after 90, it drops down drastically. And once saturation comes below 80, your saturation is too less for you to sustain life. Now, this is the most important thing, and this kind of a hypoxia can injure your brain, can injure your heart. That is why you develop a sudden cardiac arrest. Then coming to sources, now what do we do? So immediately you get perplexed. Now there is no oxygen available, nothing is available. You can do certain things. I just wanted you to, the reason is when you go as an attender for a patient, sometimes it is easy for you to sustain yourself before getting admitted with oxygen given at home, along with medical advice. Please understand that it doesn't mean that you order for an oxygen and put it in the nose and then you know everything about it. No, not at all. You have to take precaution just for you to understand, because medical jargons are creating stress among the non-medical people. If I explain to you the medical jargons, you may be better people to treat patients than what we do. It is the experience you gain which is most important, because experience teaches you wisdom, whereas reading teaches you only intelligence. So these are the various ways of oxygen resources. You have a simple cannula, a nasal cannula. Some people call it NRM, it's called non-rebreathing mask, an oxygen concentrator. You don't have to worry much about these because that cannot be handled by you people. So just to give you a brief idea of what is oxygen percentage, normal oxygen, what we get in the atmosphere is 21%. So what I'm suggesting is that most of you, after this lecture, will be able to use 21% oxygen and live happily by God's grace for as many years as possible, based on His will. So every liter of oxygen you give, add 4% to it, because medical people are usually weak in mass, most of them. So we take from 20 instead of 21. So if suppose somebody gets 2 liters per minute, which means he is getting 28% of oxygen. Because the usual simple cannula which you put in the nose can give only up to 5 liters. So 5 into 4, 20 plus 20. Maximum somewhere from 40 to 44 can be given from an oxygen cylinder. And when you use a non-rebreathing mask, all that the mentioned non-breathing mass is that you have a reservoirs and a valve. So what you are breathing in comes out through a different port and doesn't come out through the same port. So that is the advantage, which raises it to 54%. If you go in for a concentrator, most people think, what is a concentrator? Oxygen cylinder actually has oxygen stored under pressure and is getting released. But when you want to sustain it as in a post-COVID patient, oxygen cylinder is not only cumbersome, but very costly. So if you go in for a concentrator, you can use it for a long time. There are now concentrators which can run for nearly 1,500 hours at a constant pace. But you have to understand that it's after all a machine. The only machine that can run constantly without any trouble is your heart. Except that there's no other machine which is perpetual. Thanks to all of our hearts, that's why we are alive listening to this lecture, or I'm able to deliver my lecture. Nothing else is perpetual. So you need to stop the oxygen concentrator at least for 10 to 15 minutes after 4 hours. Otherwise, the filament gets heated up, and you know this better as an engineering expert. So what this oxygen concentrator does is it takes off the nitrogen, absorbs the nitrogen, and there is a relative increase in the concentration of oxygen. That is all. Nothing big. Now there are 2 or 3 types of oxygen concentrators which come. Ones which are endurable, the others which are given just as a substitute for oxygen cylinder. So the oxygen concentrator comes as 5 liters and 10 liters and 15 liters. If at all you have a patient who is having real hypoxia, you should go in for a concentrator which gives 10 to 15 liters. Again, the same mathematics. If it gives 15 liters, you know pretty well. 15 into 4 is 60. Combining with your 21% oxygen, getting a non-rebreathable mask and using it, you almost achieve up to 95% of oxygen concentration. So these are the masks. I will not go much into it. The other latest thing is HFNC, or high flow nasal cannula. This is a different mechanism where you get oxygen source from hospitals. You use the LMO, what is that, liquid medical oxygen, and that has to come under pressure, and there is a humidifier. You humidify it and you can go up to 80-90 liters of oxygen. So what do you need to know about oxygen? Your nose and your throat, they are excellent air conditioners. Not the air conditioners doesn't mean that it has to cool the air. It can cool or it can heat depending on the outside temperature. Now, whenever you're using a tracheostomy tube or when you're using endotracheal tube, this is bypassed. Hence, there is a need whenever you are giving oxygen, especially at higher concentration, to humidify or go through water. This is something which you cannot avoid. Okay, if you want to take payasam, it has to be liquid. You cannot have a solid payasam to bite. That means something is grossly wrong in the way in which you have made payasam. The same way, If you are going to use nascent oxygen, it can really burn your mucosa and literally take off your sheath. There will be ulceration of your entire throat. So anything which is beyond 10 liters given for more than 2 hours, you require something to humidify it. That is why you have to give water. So water passes through the oxygen. You have something called a humidified oxygen going in. The other important thing is the sensational news of black fungus. My colleague and senior colleague and expert, Dr. Santanu Das, really wanted me to take on this. Black fungus actually is a misnomer because we usually refer to Aspergillus niger as the black fungus or the Aspergillus family. Mucormycosis is not really black. I would say gray fungus. So the reason for the black fungus is still not known because the mycologists feel that any person receiving high amount of oxygen Santanu Das sir, am I on the right slide? Because the slides have gone.
Yes, sir.
Yeah, thank you, sir. So coming to the black fungus, the mycologists feel that nascent oxygen is not a friend of anybody. It's an indomitable enemy to all organisms, including fungi. So they are really, they are doubtful that oxygen conduit or contamination of oxygen conduit is the reason for black fungus. Now, what I would suggest is still nothing is known exactly why this black fungus is attacking with especially among patients with post-COVID pneumonia. But there are some plausible factors. One common unifying factor is uncontrolled diabetes, especially insulin-dependent diabetes, or the sugar levels are really uncontrolled for quite a long time. In the face of lymphopenia, when patients develop lymphopenia due to COVID, on top of them, if you annihilate the problem by giving steroids for quite a long period of time, now then this black fungus, or what you called as, to be very technical, mucormycosis occurs. And mucormycosis actually affects two areas. It can be otorhinocerebral, where you have problems in the nose. Patients may have bleeding from the nose and slowly develop meningitis-like thing, or it can occur in the lung. Of course, it is very confusing picture. You have to be really careful to diagnose using CT as well as the symptoms of the patients, including hemoptysis. So these are the, this is something too technical, so I will not go much into the details. As of now, you need not be worried because a patient is with oxygen. Does it mean that he will go in for black fungus problem? No, not at all. Of course, amphotericin available. You can give the amphotericin. There are no actual prophylaxis for fungal infections. So all that you need to do is clean the tubes and keep it ready for what it is worth. Again, certain people are putting the blame on zinc tablets. I don't think that that's a big reason to worry about. Of course, you have the government of India, the Ministry of Health and Family Welfare, giving you guidelines all the time, which patient has to be admitted, which patient has to be seen at the COVID care center, or which patient should be home quarantine. The general principles are very, very clear. If you don't have comorbidities less than 60 years, you're healthy and you can pass home, you are sensible enough, you don't require somebody, then you can do it at home, as simple as that. But that doesn't mean that you can be at home. You don't have to monitor yourself. As I told earlier, at least temperature and saturation have to be monitored by you on a regular basis. Now, coming to the most controversial point, I don't have any controversies in this because I go by Adi Shankara's words. He says there can be a foolish teacher. There can never be a foolish student. There can never be a foolish question. There can be a foolish answer. So this occurs in Adi Shankara's Viveka Chudamani. So he says, whatever I learned from my gurus, I impart that knowledge to you. So antibiotics. So some of the state guidelines are very clear. They have very clearly said that you can give doxy or azithromycin with ivermectin. Both ivermectin and HCQ are immunomodulators. If you're going to use immunomodulators like HCQ, there is a problem with cardiotoxicity. The person who's already having some cardiac problems with respect to rhythm will have problems. So HCQ has gone into vogue, but ivermectin has remained. There are again papers for and against ivermectin. The Western world is not very happy with ivermectin. However, whatever we have, it's a cheaper drug and it has been doing wonders. And there has been a paper. From Dr. Behera, and there's a paper in the chest recently on ivermectin prophylaxis as well as ivermectin treatment. Antivirals is creating a sensation. Remdesivir is now the only antiviral drug which is available, which has been approved by the FDA. On the contrary, the use of remdesivir is very, very specific. There are very, very few patients who require remdesivir. Those who have almost reached the stage of desaturation, nothing can be improved by giving remdesivir. This is what the most of the physicians and most of the patients attenders do not understand. We daily see queues and queues and queues standing for nearly kilometers waiting to get remdesivir, which is absolute waste of time. You can always go in for other because it's very specific. Secondly, remdesivir has to be given at a very early stage. After that, because there are always difference of opinion as well as remdesivir is concerned, the WHO is very clear to say in its solidarity trial that remdesivir has not improved mortality or severity or reduced the severity of the disease. So as of now, there are no antivirals available, and the use of remdesivir should be pertain to hospitalized patients with very specific things. It doesn't mean that if you are given remdesivir, you are going to survive. Nor does it mean that if you are deprived of remdesivir, you are going to die. Please understand this very, very clearly, and don't be a fanatic for remdesivir. Lastly, coming to most important thing is steroids. I would again ask you to go back to the slides. Give me 1 minute. Now, sorry for wasting your time. Again, going back. Please understand that the virological phase and the inflammatory phase do not occur after a gap. They overlap. So this is the physician's dilemma. I see a lot of media showing people attacking doctors in hospitals. Most preposterous, indecent way of giving us back the credit for sacrificing each one of their lives in the COVID one. This is something which I want you to understand. Very difficult for us to analyze the gap between these two in most cases. So the rule of the thumb is in the virological phase, you start giving steroids, it creates havoc. You are not supposed to complicate the progress of the disease by starting steroids in this phase. You have to start giving steroids in this phase. But God only knows when the virological phase ends, the virus replication ends, and then the immunity takes over and starts beating the lung. So this is something which I want you to be very clear about. Which the creator only knows. So as a rough rule of a thumb, when do you give steroids? Please understand, steroids are given only after 4 to 5 days. Do not start simultaneously giving antibiotics with steroids. This is the most important thing. I've seen many of the experts in the TV telling this very commonly, especially from Delhi, saying that please do not overuse steroids. However, there are practical difficulties when you look at the rural areas where they may not have access to biomarkers. Easy way to treat among city physicians, I would suggest, is without biomarkers, don't give steroids. If you look at the biomarkers, there is an increase or elevation of CRP, then you give steroids. Otherwise, just like that, starting steroids is definitely dangerous and doesn't require anything. But if a patient is developing a desaturation, obviously you look at the biomarkers. Biomarkers will increase. But here, the catch point or the trick is never give steroids and then look for biomarkers, because all of them will become reduced in levels in the blood. You will not be able to, once you give a single dose of steroids, you will not be able to assess the biomarkers. So I would suggest, to the extent possible, do the biomarkers and then give steroids. What kind of steroids? Leave it to the physician. It doesn't mean that dexamethasone works. Initially, the preliminary thing on methylprednisolone works. They're all like, let's say, one professor substituted by other professor. The way in which every person teaches differs from each other. There's not much difference. But however, based on the duration of the steroids, the time required for the steroids to act, the physician can guide whether he wants to give dexamethasone or methylprednisolone or hydrocortisone. So there is a way in which to find out, which is too technical. I don't want to go, but steroids definitely play a role, but not giving simultaneously, because they are a double-edged sword. That is again another cause for this black fungus and other complications. Secondly, steroid should be given in patients who have at least had 3 or 4 days of symptoms or 5 days of symptoms, and then their biomarkers have started elevation. Again, I tell you, the simple thing for you to understand is you are killed by your own immunity, not by the virus. So giving the steroids at the initial phase, you are actually asking this innocent virus to start killing people. So please don't start steroids simultaneously. That again is another caveat which you need to understand. Anticoagulants are determined by D-dimers. There are certain instances where there is hypoxemia, where you don't have access to D-dimers. You can give empirically. D-dimers are not going to, for a short period, because D-dimers, the low molecular weight heparins and certain drugs which act directly on the factors like rivaroxaban and other drugs are available. They are very safe. It is not like heparin and other things where you are going to bleed from your orifices. No. So in the event that you do not have access to medical care, you do not have, then it's a very good drug. Otherwise, the basic tendency to give steroids initially, that has to be avoided without proper documentation. However, a patient who is having a desaturation, if you don't have access to biomarkers, doesn't mean that you have to wait. You can start steroid, but not simultaneously, because your saturation rarely reduces by the first 4 or 5 days. Your saturation begins to decline. Most commonly, the crucial period is between the 6th to 14th day of your symptoms. Unless you ignore your symptoms, which has occurred earlier. You say, I have only a small dry cough, something like that. That is where you need to be careful about. This is where we have very clearly shown in the recovery trial, WHO, that steroids are helpful. Any type of steroids, as you can see from this, that it depends on the doctor, the familiarity of the drug which has been used, and the experience of the doctor. Based on that, any steroid will help. Then what are the general measures we need to follow? Social distancing. Most of the times we see that during meetings, even learned professors take off their mask and start talking and then close the mask. This is not because of the wisdom, because we are not used to. As a natural instinct, when we talk, especially, it's a very common thing that when somebody comes in between two people who are talking, what do you say? You just say, you better get out of my sight. I'm talking to this guy. So that's a very common human instinct. I would say that it's a common human habit. As a courtesy, we do not want to have, we want to have an eye-to-eye contact. And we feel that the mask itself reduces our eye-to-eye contact. So that's how I psychologically, I take it. So, but the most important thing is you require to wear a mask when you are talking. That is where, and if it's an enclosed space, you have to increase the people don't understand the wearing the mask. I'll come to the types of masks a little later. When you are talking, when you have a situation where you don't have a mask, let's say you are going to just gargle your mouth, and you have another person who is coming near you. Now is the time for you to take every person as COVID positive and take precaution, especially at work site. Even though you may be working with a 50% or 40% staff, that is the time where you have to maintain social distancing. You can't keep coming closer to that guy and keep talking, because talking disperses the naso-oral secretions, oropharyngeal secretions almost up to ½ meter. When you cough, it becomes 2 meters. When you sneeze, it becomes 3 meters. So the rule of 1, 2, 3 plays. So that is where you have to be really careful keeping social distancing, especially when you are talking. If you are going to meditate, this problem will not arise. The same thing, what mask to use? People are actually worried. Should I take an N95? Most of the people don't know that a real N95 is very, very claustrophobic and you cannot use it. So the best thing to do is to use an ordinary mask, a cloth mask, when you are speaking to for a person inside the house. Like what I mean to say is, when you put it, let's say we have a patient at home who is COVID positive, put the cloth mask over this thing and you wear the mask and sit down. At a distance of 3 or 4 meters, you can talk. It doesn't mean quarantine means it's Sita in Ashokavanam, where you have to, the Ravana has prevented anybody from coming near except Vibhishana's daughter. It's not like that. You can open the door, you can keep a safe distance from the patient, masks on both faces, and then you can talk. The reason I'm telling you is, this is the social bonding which is required. We are not socially separating people. We are only social distancing. It is not social separation, as rightly pointed out by Prime Minister in one of his speeches. What mask to use? This is I have told you the cloth mask is more than sufficient. But when it comes to a crowded area, you want to go to the market, it is better to use an N95 or some kind of a better mask. But what if you don't have an N95? Now it's a lockdown. Now they recently opened a lockdown. I have only an ordinary cloth mask. Then the best bet would be using a visor or a face shield. A face shield protects you, makes your cloth mask itself as an N95. This is where you understand. You want to go down. Let us say there's a common repair. There's a fire somewhere. You want to help somebody else. Put a face mask, put a common face shield, and then have a gloves and go and talk to the person. And sanitization, we see you don't have to be much more. Now we know that the fomite transmission is little less. It is not that you are going to touch anything that has to be put into sulfuric acid and then removed. Nothing will be there if you do that. You don't have to sanitize newspapers. You don't have to sanitize currencies. You don't have to sanitize other paper, research papers. Nothing needs to be sanitized. It is your mind that has to be sanitized, knowing that what I have to do. So all that you need to do is wash your hands. Again, you don't require the best of alcohols for you to sanitize itself. All that you require is soap and water, because you know that it's lipophilic. Just using water alone will not take the virus from your hands. So you have to use soap and water, and practice not touching your face. Trying to open your doorknobs with your left hand. Of course, it looks a little disrespectful. What Corona has actually taught us is the culture. You go wash your hands, wash your feet before entering your house. You put your clothes in the washing machine, or you wash your clothes yourself. So some kind of a natural this thing, and please add your tulsi, your ginger and all these things. Nobody says no. They have proved medicinal value, especially in traditional medicine. I am not against traditional medicine. All that I'm saying is, but please give enough respect to modern scientific medicine and its precautions. With this, I will complete my lecture, and I am open for any questions, and I thank wholeheartedly the entire group, because it's already 5:15. You have been listening to me for nearly 1 hour. So I thank you, and I thank my director for giving me this opportunity. Thank you so much.
Thank you so much, sir. The first part, as you could see, that it was for common understanding, and next 20-30 minutes it was technical to understand, especially for those technical people, or for the patients, or for the people who are handling them. So there are a couple of questions. So the forum is open. So if anyone has any questions, please do ask. You are free to type the questions so that our esteemed speaker can answer one by one. So the first one, what I could see from Nandish, can I trust the result given by the mobile oximeter app, which works on the principles of plethysmography?
The plethysmography is for the BP recording. So everything is actually colorimeter or photometer. So it has been made sensitive enough. It will be good if you can titrate it with a pulse oximeter got from a neighbor or somebody. But it is not that it is totally useless. It is almost comparable, but nobody has done any study. So we cannot concretely say that, yes, this is accuracy is this much, but definitely you can use it in the absence of anything else.
Thank you, sir. The next question from Dr. Ashira Banu Sangli, madam. Does blood thinner decrease the COVID infection?
After listening to me, you would have understood very clearly. that the clotting which occurs, the microcoagulation that occurs in the lung, as well as the inflammation, is created by our immunity. Whenever inflammation is created, what happens? The lung is in a closed pack. You have like this is the blood vessel. Now I'm compressing this. Let's say it is a plastic tube, and I start compressing this pen. Automatically, the ink will squeeze and that will get clotted or something like that. That is the phenomenon which occurs in the lung. So it has got nothing to do with COVID infection decreasing. All that we are trying to do is make the lung viable, the blood supply to that part of the lung viable, so that it performs its function. Secondly, this clotting can occur anywhere. It is not clotting problem, it's a coagulation problem which can occur anywhere. It can occur in the heart, it can occur in the brain. So you can have predisposition for strokes as well as predisposition for heart attacks. So blood thinners are used based on the D-dimer levels. And in specific instances, there are certain conditions where there is a high risk group. You can give blood thinners irrespective of the D-dimer levels. That is too high for you. But blood thinners has got nothing to do with the COVID disease as such. It has to do with complications of COVID. It reduces the complications of COVID. If your D-dimer is elevated, usually we say 500 nanograms. If something is above 750 nanograms, that's the starting danger point. Anything above 1000, it's better to use blood thinners, and there are a specific group of blood thinners which are quite safe. So it is not that you need to keep on monitoring the blood bleeding time, clotting time, and other things. It has got no major bleeding tendencies. It's can be very safely used, and it's life-saving.
Thank you, sir. The next question from Dr. Thirumaran. We learned how now that those below 18 years of age are also equally vulnerable from getting infected. While the vaccination drives are focused on those above 18 years, what or how can the school-going children of teenagers below 18 safeguard themselves? Is there a vaccine in the making for below 18?
So I first declare my conflict of interest because he works under me, and I'm really, and I know he can block me. So that's a fantastic question. Actually, all the vaccine trials have now oriented and moved towards lesser age group, because we used to call it as a multi-inflammatory syndrome in children. Very, very commonly it is occurring. As the vaccines are being slowly taken into the school age group, these trials are already ongoing. So very soon we can have vaccines, because that's the only salvage for us, because children are equally vulnerable. That's what we have found out in the second wave. We initially thought that the first wave, they were immune to the first wave, but they are equally vulnerable. It is understandable because the virus also has to survive. It is survival of the fittest. The other things are that when you are going for certain countries, the UK and US have already started using the rat test. They use a urine test. Every day you have to report that through WhatsApp to the teacher, and then only. But before that, what I mean to say is, we don't have to get too much panicky. I do not have the exact answer. But what I mean to say is, it will definitely have a limited course in children, at least, because the immunity is not as mature as adults. But vaccination will slowly get into them also. Till such time, we have to maintain those precautions, which are not very, which are not practically, it is a little difficult. So till such time, we have to make use of 50% or 40% of children attending the schools. Instead of physical presence, we can have Zoom, except for the higher standards. We have to manage the way for some time, till such time that we can understand the virus.
Thank you, sir. There is one question that when a patient has been given, once a COVID positive patient has been given with steroid, so it is like that the glucose level increases in the body. So once the steroid has been stopped, how the steroid should be stopped, and once the steroid is stopped, how long it takes the glucose level in the body to come down, the elevated glucose level to come down?
That's an excellent question. See, most of them sometimes blame the doctors for giving steroids. You have brought it on me, that diabetes. They don't understand that you are allowed to complain to the doctor because of the steroids. So that is the catchment point. So what I would say is that definitely steroids cause increased hyperglycemic status, which is known. It is not something unknown. The physicians to discuss with the patient, especially a non-diabetic or a diabetic, telling them that this is what will happen and don't worry about your sugars for some time. And when you start tapering it, there's the other funny thing is that most of them the sugar levels will get down. But there are certain people, like what you say, gestational diabetes, pregnancy uncovering diabetes, like that the patient is already in a pre-diabetic status. Giving steroids may make them permanently diabetic. But this you cannot help it, because more importantly, you want to save the life of the patient. Like a fish out of the water, the patient will be gasping if you are not giving steroids. So our main aim is to see that you give a better quality of life. Diabetes is not something which we cannot handle. We can definitely handle that only with proper titration. So this possibility is there, but it is minuscule. But for most of them, the threshold will definitely end. Exactly what day, that I think I'm not a specialist to tell that, because diabetologists may know this better.
Tentatively, approximately how long it may take the sugar level to, though we know you are a pulmonologist, but as you are treating the COVID patient and you will be knowing, so just out of box, we are asking how long it may take the sugar to come down.
Sir, I would suggest that if the patient is not a diabetic, I would not go in and do the blood test at all for him for a month till the entire steroids, because steroids have got what is called post-inflammatory effect. After a particular time of point of time, also their effect will lost. What is called post-therapeutic effect. You can stop the steroids, but the effect of steroids will be there for quite some time also. So I would not venture into it, and it doesn't make a person with like say blood sugar normal of 140 to, it doesn't make it as 300. It will make it as 180 or so, something like that, which you can always permit. It's permissible hyperglycemia after post steroids, which occurs more commonly at the higher age groups. It doesn't occur with the lower age groups. If you take a guy of around 20 years, by 1 month, it's hardly by 1 month, 90% of these guys who's 20 age group will come down with their sugar and they have normal sugar. So it's multifactorial. So there is no clear clear answer to this. But we have not faced this problem in any patient, sir. But as far as diabetics are concerned, we have to change from oral hypoglycemic drugs to insulin, because insulin gives a better control because of its anabolic effect, especially under the influence of steroids.
Yes, sir. Thank you, sir. The next question from KS Ananya. In the first wave, it was 40 plus. Now in the second wave, it is 40, less than 40. Why it is so? It is the same virus, but why it is so?
That's a very good question. That's what I was answering. It was, in fact, Dr. Thirumaran's question was almost something related. See, the second wave, the infectivity is more, and if you look at the age group, this is the age group which goes out and comes out and comes in. I would call it as the mice age group, because these are the people who are voluntarily going out of the house and coming back. If you look at the elderly, most of them, after looking into all these media, looking into all these things, usually they are taking proper precautions not to go, and we have started the vaccination drive on the elderly. So the people who are now prone for this infection, this is one cause. I will not say this is the main cause. This is one cause. The people who are main prone for infection, the age group has come down because the others have got vaccinated. The same way, the third wave, people are predicting it will come into children, because now we have gone up to 18 years of age. So the vaccination, if it's going to cover 18 years of age, the vulnerable people are those who are below 18 years of age. That is one thing. Secondly, the wave is different because every day virus is mutating. It doesn't mean that if the virus is mutating, everything will happen. But there may be, we are seeing that. In fact, in the second wave, we are seeing more males. In the first wave, it was equally distributed among males and females. Now we are seeing more males being affected than females.
Okay, so pertaining to that same question, I have a query. Is it like that as more males? So is it like that as you told the mice syndrome, males go more out? That's the reason males are affected, or how is it? Or is it anything gender biased?
Maybe, sir. Maybe. As of now, there is no evidence to say that it is gender biased. You may be right.
The next question from D. Kavita. A person after getting vaccinated, if does a RT-PCR, sometimes within a day or two also gets positive. Why and how?
See, RT-PCR positive has got nothing to do with vaccination, because they are subunit vaccines which are being given. If you look at the Pfizer and Moderna, they are mRNA. If you look at the Covaxin and the Covishield, all of them are actually the adenovirus. The Covishield is the adenovirus carrying the spike protein, whereas the Covaxin actually is the dead virus. So they are not the, so if you have RT-PCR positive, it is already, the disease is there in the patient, which has not been diagnosed initially. Now they are able to diagnose, because this controversy was lingering for a long time. Say that after I had the vaccination, there were rumors that patients will have an unmasking of their COVID disease. No, it is the pre-existing disease which was showing through more commonly because of the vaccination. Again, that's a good question, because here is a bit of caution. Any patient who is vaccinated has fever beyond 3 days, don't think it is vaccination. You better consult a doctor, because it can be anything else, including active COVID disease.
So related to the moment a vaccination is being given, some patient develop fever within evening. Suppose morning they got a vaccination, by evening they get fever, or some people have the mild headache, chest pain or body ache completely, and it goes on for a day or two. Is it normal, or there is something to worry about?
My signature is different from yours, as simple as that. You cannot expect everybody to behave the same way, even inside the house, or same person behaving the same way on all days. So variation is the elixir of life. So you can be, not that every person should have this, but most importantly, we have to, I have not covered vaccines basically and wantedly, because one of my colleagues may be taking it. So that is the reason I have not covered vaccines. Most importantly, we see people have lots of weakness. Almost it reciprocates or reflects the disease process, because that's the idea of the vaccine. The immunity will have to, you have to take that it's a dummy villain and start fighting and keep walking at the villain. So that being the reason, you will have the same symptoms and signs of what a COVID disease will have, but not too much of it. You will have fever. Most importantly, we see exhaustion. It's a very, very severe weakness. But this goes off. That's why if you are vaccinated, at least 1 or 2 days, you have to take rest. People think that they get vaccinated, they roam about doing their same job, same routine. That needs to be, you need to be, take a little care trying to take some rest. And plenty of fluids.
Yes, sir. Thank you. The next question, self-COVID test kit is available nowadays. How accurate you feel the results are?
It has been actually released by ICMR. So hopefully, without seeing the records, I don't think ICMR as an institution will allow the self-COVID kits. But the most important thing is, like self-medication, when you say something is positive, see, people, there are always the good and bad of any motive or any investigation or intervention or therapy. So don't think that by you are doing it, you're okay, you are COVID positive, you can sit at home. So the most important thing for anybody is, when you are COVID positive or when you have suspicion of COVID, is to consult the physician. That is most important. My talk is that not that everybody needs to rush up and then put an oxygen on their nose and then only they are saved. No, that is the panicky which is going on now. And that is why hospitals are really full. And people think that's a hopeless situation in India. Not at all. Obviously not. I have shown you the statistics. More people have died in other advanced countries compared to India. And physicians have been trained enough. They have got gained enough experience nowadays, and they are able to do a wonderful job. The only thing is whom to prioritize, how to triage, and lots of oxygen plants have been installed by the central government as well as state government. So it's just a matter of time when they take up, and then we are able to manage the situation better.
So 2 questions here. One is, when this pandemic, the second wave, what you feel we should be cautious enough, because already entire India, one or the other state is going under lockdown. So when you feel like last year, but it was for 40 days, how many months you feel that after that it will be again come back to the normalcy, means with mass social distancing and we can get back to the work?
The basic reason for the second wave, I feel, is the responsibility of all of us. Most of us have actually, a small group has really has paid keen ears to what the instructions have been given. But unfortunately, most of the times, a lot of factors have worked into this thing. Of course, India is a country of diverse variations and economy. So it is not easy for the common man to maintain these things. However, if everybody has, what I mean to say is, everybody listens to the teacher, then there cannot be a student who is scoring less than that. So that is where things have failed. But there's no use in blaming any of us. because we are part of the government, and this is the time in which we have to shoulder responsibility, work in unison to see that we succeed. However, I'm neither a bureaucrat nor an epidemiologist to tell this. However, we feel that because of the lockdown actually is brought about to gain time so that we are able to match with the increasing demand. The lockdown is not brought to hamper somebody's life, somebody's activities, not at all. It is being brought down for the only intention that you reduce the phase of acceleration or try to increase the phase of decline by lesser numbers, because it's an epidemic. Please understand this. One person infects two persons infect four. It goes in a logarithmic cycle. When you bring a lockdown, there's a logarithmic decline. That being the case, there will be less cases to attend. There will be less transmission in the community. In such a way, it gives more time for people to take corrective action at all levels, starting from home up to the state, up to the nation. So that is how the lockdowns are being affected. So there is no specific period. It depends on individual regions, how the transmission goes, and accordingly you have to tune and titrate your lockdowns. That is what is the government doing.
One question here, because most of us or most of the common people are worried about the moment if anyone gets no touch wood, God forbid, nobody should get more affected and COVID positive. If they get, is it fine they go for teleconsultancy? What is the difference between teleconsultancy and physical consultancy?
Sir, I was one of the physicians who was right against teleconsultation before COVID. The reason is because unless you have your basic contact and eye contact with the patient, there's a lots of psychological interaction which goes on between the physician and the patient. So you know better. So seeing a person like a son who has been away from his mother, seeing the mother itself gives him joy. Like that, seeing the patient, listening to the physician itself gives joy. That is how we have been brought up in India, at least in Indian culture. We are not like the Westerners where you are a consumer. So whatever you do, I'll just throw you into the machines, get the investigations done, and then only even look into your face. This is not, our medical system is highly developed compared to the other systems in the world. This is something which has come up. There are lots of patients who even now say that talking to the physician itself reduces my ailment. It has cured me of my illness. To how long, to what extent, that's a different issue altogether. But however, if the current situation demands teleconsultation. So the best thing for us to do is using the teleconsultation, because we are not going to put just by not putting the step doesn't mean the doctor is not interested. That is how now I have refined myself, I should say. Now we look into the patient, we call the patient. Teleconsultation again is not just through, most of them have got WhatsApp. I'm really, it's a strange thing that if very few people I can see on the roads not having a cell without a Android or any other make where we are not able to see his face. So using the WhatsApp or using any of the video calls, we can call the patient, we can talk to them and ask them to arrange things in such a way that we are able to successfully deal with the disease. We are able to do teleconsultation in a very good way. And we can refine the patient. Those who require definitely physical examination, like a patient with an alternative diagnosis. Let's say a patient has got a coexisting malignancy, patient has got a coexisting thyroid, something like that, where you want to see patient has got severe abdominal pain, something like that, you want to rule out other causes. Then you can go ahead and do the examination in a very, very protected way using your PPEs. So definitely teleconsultation helps at least to allay anxiety. I always talk with my patients at least for 30 to 50 minutes, then anxiety goes off. Because everybody is a human being. But if it's going to be a teleconsultation where you just throw the prescription, you throw the investigations and throw everything and then not talk to the patient, then that is not teleconsultation.
Yes, sir, we should. And we are lucky. On the records, I would like to put you all that Dr. Narendran Gopalan is one of the colleague of WHO's chief, our Swaminathan Madam, who is a daughter of our green revolutionist MS Swaminathan ji.
She's my guru, sir. She's not my colleague.
She is a guru, so obviously we can feel how in depth our Narendran sir is. So still questions are few. We'll take some important questions. Sir, if a person is affected in the first wave, how much chances are there he may get affected with the second, and how much will the antibodies be protecting him or her?
Sir, we are not able to say at the current. There are certain patients who had got the second time, they got into problems the second time. There are certain patients who have a very mild second time attack. So that is what is very important, which people have to know, that just because they had an attack of COVID doesn't mean that it makes them immune against a second attack. But vaccination, we have seen, really reduces the morbidity and mortality. It doesn't mean that you will not get infected. That's again a wrong notion which the people start complaining. I already vaccinated, I am COVID positive. That is again, if a patient is vaccinated, again at home, you have to take proper precautions because they may not suffer from the disease and they may be asymptomatic carriers. So the others have to be really careful. That is the younger age group. So that is where you have to be really, this virus is really tricky because we are learning from it every day. We do some sort of intervention, it tries to escape through some other route. So
because mostly we know that it is a mRNA virus.
Yeah.
Sir, the next question from Kailash ji. BCG vaccination at infant stage, any inherent immunity to Indians? Second question, buttermilk with lots of bacteria has any killing effect on virus? Buttermilk with lots of bacteria.
I am one of the connoisseurs of buttermilk. I take at least 1 liter of buttermilk every day, especially in the summer season. So irrespective of whatever it is, buttermilk is something which is useful for health. It has got nothing to do with virus. Tulasi is helpful. Turmeric is helpful. Pepper is helpful. We know that these have medicinal properties time immemorial. It doesn't mean that specifically we have to prove against this. It gives you good health to see that you are not affected by any virus, anything. But doesn't mean that because you are taking buttermilk for COVID, you are going to get cured. Nothing like that.
Yes, sir. The next question from Rashri Patki, madam. Post-infection, a person develops antibody against the virus. So the vaccination is delayed by 3 to 4 months. Is it applicable, or we can take immediately post-infection?
No, the guidelines are very clearly said that the guide you can postpone it up to 30 to 45 days. That's the recent guidelines which have come out, which have been issued by the Health Secretary of the Government of Tamil Nadu, and very clearly they have said that if you have an infection, you just wait for some more time. There are two reasons for it. One is that you just wait for the other problems of infection to handle. The second thing is you give a chance for the other guy who is not at all infected to get vaccinated so that he can be protected. So it's a community ethics.
Okay. Next question from Vidyashri. What should we do to keep up our immunity during this pandemic?
That's an excellent question. Simple answer to this is keep yourself out of stress. But it is not very easy to practice. So the best thing for us is to listen to music, have social gathering within the family, meditate, do your pujas, and think that this is what my Guruji told me when he belongs to Swami Shankar Maharaj from Ramakrishna Math. This is what he said. He said that when I said, Swamiji, I'm going to now tackle COVID, what am I going to do? I'm the breadwinner, I'm the only breadwinner of the family. He said that please have faith in God. It's not that because of Corona that you will be killed, or you will be Chiranjeevi, you will not have death at all if there is no Corona around. It is not like that. So have faith in God. And one of my very senior colleagues, Dr. Nageshan, who was my pediatrician, he was almost 86 years old. He was still practicing in the pandemic period. He said that having born and now having taken up this profession, I cannot go back. I have to treat patients. That is why I have taken this profession. Imagine what will happen if the army man says that I'm not going to, the war has come, so I'll come home. I'll take leave. So on the one hand, I was really astonished at his courage as well as his dutiful words. So this is the time in which we need to be very much cognizant of these developments and try to help each other. So this is the way to reduce stress. Most important point to reduce stress is to have family gatherings. All of us sit together and take our food. This is something we usually is not possible for us without the lockdown. With the lockdown, the lockdown was not there. The elderly will take a little earlier. The people who are going for work will take at a later date. In fact, it is useful for the housewives also to serve food at the same time to everybody. I have a private chat with each other.
Sir, how long the antibody in our body stays?
They
For the
say it
vaccination,
stays.
what we are taking,
It says
Uh,
the important point is even you see the immunity once you start challenging with an antigen, the immune apparatus takes memory cells. So what I mean to say is you if you look at the immunology, both memory T cells and B cells will be there in your body. Some of them neutralizing antibodies will be there in your body, and slowly they decay when the antigenic response is taken out. That means as COVID pandemic reduces, your antigenic response, your antibodies production, your T cells also will reduce. But there will be memory in the immunity. Once again, there's a when it strikes again, it will be helpful. That is the reason why now they say that even after vaccination, maybe you may have to have a revaccinated maybe an year or so to have a constant triggering of these memory cells. But what is more important is when you're vaccinated, the mortality and the severity of disease presentation comes down drastically. This is what people say. Even though you may contract COVID, you may not have suffer from the aftermath of COVID, or you may not suffer from the ill effects of COVID to a great extent. That's what they say. Up to 6 months. Up to 6 months, you will have these antibodies. That's the maximum period of time. After that, it may decline.
So is it like that every 6 months we have to take again vaccination?
We are not sure now, sir. We are not sure now. Maybe 1 year. Let's see. Even the flu vaccine, you take it every year. You don't just have a flu shot in 1966 and say you are protected in 2021. No. So, but we need to learn, because now only vaccines are rolling out. We need to learn. We are in the learning period actually.
The next question from Preeta Ghosh. The pathogenic nature of the COVID variants has any role in triggering the cytokinesis storm in patients during second wave?
I don't have any answer, because that's a very, very technical question with respect to immunology. See, the cytokines, the basic problem with cytokines is it's some kind of what you call it as immune reconstitution inflammatory syndrome. The immunity develops and that hits your body. So there are the cytokines, they have a very strange property. They are redundant as well as pleomorphic. Pleomorphic in the sense that they have multiple functions. Redundant in the sense that one cytokine, multiple cytokines can have the same function. That is why your tocilizumab has failed drastically, because it only blocks IL-6. It is so what I mean to say, there are hundreds of other cytokines which can cause inflammation. There may be one cytokine which has multiple things. So it's not very easy for us to just say that yes, this person is not available, so you will not have it, or this person is in greater amounts. So that is the reason why we are not now looking into IL-6. We are now looking into CRP, which is the downstream mediator of most of these inflammatory markers, cytokines, which is secreted in the liver based on the macrophage or any of this immune system creating these cytokines. The liver starts secreting CRP. So the ultimate end product to say that there is inflammation is the CRP itself. So you don't have to have complicated investigation, because to evaluate the levels of cytokines, one cytokine requires at least 40,000 rupees. So if you say I want to just look into very specifically, and because of these problems, you can't name them. Just you pick up 10 cytokines, you can't name them. So for that, you spend 4 lakhs. Instead, you can judiciously use that money to buy a ventilator, or not a ventilator, concentrator for your entire community in your locality.
Yes, sir. The next question from Surekha Vedvachalam. On an average, eosinophilic ratio is seen higher in common people. Why is it so? Is there any specific reason for this pandemic period?
We have not seen eosinophilic ratio higher or anything like that. So all that we are seeing is a neutrophil bar lymphocyte ratio, which is much more significant. Eosinophils can rise because of various other reasons, including parasitic infection. We are also seeing a slightly increase in immature monocytes, which is also seen. But I'm not very much familiar, and I don't have the answer, because we have not seen this eosinophilia, and we are seeing it for other reasons also, not specific for corona.
Okay, sir. The next question, Dev Singh. We can hear that Covishield vaccine remains more in stock as compared to Covaxin. Which one is best to take? Because Covaxin is, as you told, it's a dead virus or killed or attenuated one, and Covishield is a subunit one. Which is more effective?
As per the current data, both are effective, sir, because the reason why I'm saying is the vaccines are effective. Whatever you are getting it available, please put it, because it helps against morbidity and mortality. It may not protect you against infection, which is not a very important thing. The important thing is you don't get hospitalized, you don't suffer from the effects of active COVID disease. So as of now, there is no huge differentiating data because some regions have said a slightly higher for Covaxin, whereas the other regions have said a slightly higher level for Covishield. They are on an average between 75 to 80% efficacious. So there is nothing to choose. Whichever is available, please put it as per the guidelines issued by ICMR.
Okay, the second last question, sir. Virus circulates through the blood, but why does it affect the lungs alone? Will it affect other parts of the organ also?
See, that's very simple. See, the virus actually gets into the cell through the receptors. So the receptors which are important are the ACE receptors. So the ACE2 receptors are actually present predominantly in the blood vessels, predominantly in the lungs, and based on the gastrointestinal tissue. And it not just confines itself to the ACE receptor. There are other receptors also which are present in the gastrointestinal tract, which are present in the brain. So literally, if you look at the receptors which the virus can enter, those receptors are distributed everywhere. That is the reason it is becoming a cosmopolitan and causing problems everywhere. It doesn't mean that in the blood vessel means it just is there in the blood vessel alone. It's based on receptor induced entry of the cell virus into the cell.
Yes, sir. The last question, Bhagyalakshmi madam, can you ask the last question?
Yes, sir. Good evening, sir. I am Dr. Bhagyalakshmi from Government RC College, Assistant Professor, Department of Commerce.
Yes, ma'am.
I am very thankful to Dr. Narendran Gopalan, sir, who has given you a wonderful session on the effect of COVID-19. And I also congratulate the Seshadripuram College for organizing such a wonderful national level seminar. My question to the doctor sir is, it's my personal question actually. My husband is vaccinated last month, that is 26th April, that is Covishield. I have not taken still vaccination. So now my question is, now Sputnik vaccination is come from Russia. So that one dosage is enough. That is what I heard in the news and all. So can I go for the Sputnik since I am not still vaccinated? That is my doubt.
We don't have any experience in Sputnik because it's just come into the era.
Yeah.
So you should ask the Russians, not me, unfortunately, because I don't have experience. See, the only difference between a practitioner and a researcher is that when we don't have experience, we very genuinely admit that. So I humbly admit that I don't have experience on Sputnik. Don't mistake.
Thank you, sir. Even I also, as an Indian, I would also like to take an Indian vaccine only. So Covishield and so my sister is also a nurse. So that just
it is a collaboration with the Dr. Reddy's lab. It is not just Russian alone. Now slowly the patency will go away, and then Dr. Reddy's lab will the company will take it up.
Okay. Thank you, sir. Thank you so much.
Sir, one question from Samarth. Are you vaccinated?
Sir, I've already told that personal questions need not be asked. So if there is a scientific content behind what he's able to ask me, I can answer.
Yes. Rajni ji, patients recovered from COVID but already having breathing issues or hypertensive, how safe to take vaccine? Should they go for any CRP?
As of now, we have not had any documented evidence of any patient going for ARDS or any patient going in for cardiac arrest because of vaccination, sir. There are some reports that patients have died and other things, but nothing has been actually implicated as due to the vaccine. So they are quite relatively safe. And the other important thing is, if you look at the benefit risk ratio for anything, there are people who have died of taking a tomato. But what is the number of people who have taken the tomato and successfully tasted it and enjoyed the taste of tomato compared to those who have died? It is a very minuscule population. So if you look at the benefits compared to the risk, the benefit ratio is somewhere very high for vaccination. That is what I would suggest.
Sir, the last question. Sir, is the ladies get adverse effect if they get vaccination during their menstruation cycle?
They have actually now clarified that there is no such thing like that. But basically speaking, usually during the menstrual period, the ladies usually will have more of pain, discomfort, as well as exhaustion. So this will add on to the exhaustion. That is all. So it is better. There is no clear guidelines that yes, you should not get vaccinated during that period. because now that with the lockdown, there will be camps which will come around in the same area. In such a situation, it is always good for them to get vaccinated rather than going to some other place farther to get vaccinated. Right at their doorstep, if they are going to get vaccinated, that time they need not worry about dispenses.
Yes, sir. So we are overwhelmed. And in fact, we are seeing it's more than 2.5 hours you have been speaking and enlightening us. So we are in dearth of words to thank ICMR, your guru, Dr. Soumya Swaminathanji, and NIRT Chennai, that we are privileged, Seshadipuram group of institution, to have the series of lectures by ICMR experts. We like to request our principal, beloved principal, Dr. SN Venkatesh, sir, to render the vote of thanks.
See, it is my privilege to propose the vote of thanks on this occasion. And first of all, I am thankful to the Narendra Gopalan sir, Dr. Narendra Gopalan sir.
Thank you, sir.
A wonderful and exhaustive, lot of ideas, lot of the things you given to us. And as a Seshadri group of Seshadripuram Education Trust, on behalf of Seshadripuram First Grade College and from the Department of Biotechnology, Biochemistry and Genetics, I am thankful to you, sir, for this wonderful workshop. And your guidelines always helps us. Definitely, we're all vaccinated, and definitely we will hope that your goal will achieved. Thank you, sir. Thank you once again. And I'm thankful to Dr. Ayyappan for presence on this occasion. It is my duty to thanks Dr. Ramesh to present on this occasion. I'm also thankful to, because backbone of the entire things is none other than our biotechnology head of the department, Professor Shantanu Das, and who did a lot of work behind this. He is a backbone for this, and I'm thankful to Shantanu Das sir on this occasion. And I am also thankful to all the faculty members, all the participants, students who are present on this occasion. Above all, for doing this function, our management was supportive. Without management support, we cannot do anything. And especially in our management, none other than our Shesh Narayan sir, and who is joint secretary to our Seshadripuram Education Trust, who always with us, supports lot of things, who preside over this function. I am thankful to Shesh Narayan sir on this occasion. And I am also thankful to all the students, all the participants, all the faculty members who are there on this occasion. Thank you, one and all.
Thank you so much, sir.
Thank
Dr.
you.
Narendran, thank you. On behalf of KSTA, Karnataka Science and Technology Academy, I would like to thank you immensely for a very illuminating talk. Our Honorable Chairman joins me in thanking you once again. Thank you very much.
Thank you, sir. Thank you so much, sir.
I also thank Seshadripuram College principal and my friend Shantanu Das and administration for arranging this webinar, and all the participants. Thank you very much. Thank you,
sir. Thank you, sir.
Thank you, sir. So may I request Ayyappan sir to speak a few words? Experts' advice.
No. Please don't say expert advice. It was so heartening to listen to Dr. Narendran all this time. The exposition from the expert in the field, pulmonologist, and with such a fact, it was a fact check for all of us. Dr. Narendran, no words to thank you for bringing before us, amidst all these confusions, such clarity in handling the pandemic. Grateful to you personally and from the organizations that have organized this meet, and you have taken such pains to talk to us from Chennai. Grateful to you. Equally grateful to Professor Shantanu Das for organizing this talk. To everyone, thank you very much.
Thank you, sir. We'll go look forward the next series. Thank you, sir. With your blessings and guidance, we'll keep more such programs to create awareness, and let us be compassionate, empathetic, and human. Thank you, sir.